Great job, Karen. I'm Greg Keoleian. I'm the director of the Center for Sustainable Systems based at SEAS. Part of our research focuses on measuring environmental impacts of food. Last year at Food for Thought, I presented on our work on the carbon intensity of diets. It's my pleasure today to introduce Kendrin Sonneville, and she has a doctorate of science in public health nutrition from Harvard. She's also a registered dietitian. At Michigan, she's an assistant professor in nutritional sciences in the School of Public Health. She also has an appointment as a research assistant professor with the Center for Human Growth and Development. Her important research and work focuses on the prevention of eating disorders among children, adolescents, and young adults. Even at this stage in her career, she has already established herself as a leading expert in this field. Evidence of that, she has 50 peer-reviewed publications already. So she has a strong tenure case. Kendrin also holds an adjunct appointment at Harvard Medical School and is a collaborating mentor for the Strategic Training Initiative for the Prevention of Eating Disorders at Boston's Children's Hospital. Ready for her favorite food? Steamers. Does everybody know what steamers are? If you're not from the East Coast, they're steamed clams. They're excellent on linguine. I'm not sure we're going to have them at the reception. They're not quite local, but please join me in welcoming Kendrin.
Thank you for that nice introduction. I wish the chair of my department was here here to hear about the strong tenure case that I apparently am. It's also an honor to be here. I think I agonized about my favorite food. I love steamers, but I love lots of foods because I'm a nutritionist. So I've gone through the hard part of identifying my top favorite food, and now I can just go on and give my 5-minute talk. So I want to start by having you all think about health and nutrition. And specifically think about the ways that we talk about these concepts. Think about the ways we talk about these concepts in public health campaigns, the ways that we talk about nutrition and health in doctors' offices. And I understand this room is not necessarily a random subset of the US population, but think about how you might talk about nutrition and health with your peers. Sort of what are the things that you think about? If the word weight came to mind, I would not be surprised, because the way that we talk about health and we think about health in this country is quite weight normative. That is, weight is prioritized as the main determinant of health. We think about food being nutritious and sort of how it contributes to weight. We use weight as a proxy of good health in low weight individuals and as a marker of poor health in individuals with higher body weights. And there are lots of examples of weight normative practices in public health and in clinical practice. So I show here 2 examples. The first is school-based screening. So in many states in this country, it's required that we do BMI screening in schools. What that means is we weigh and measure kids, we calculate BMI, and we send home letters to parents. And we indicate to parents whether or not their child's weight falls in one of these categories. And of course, we put a big red box next to the category of obese, suggesting that this is a problematic, right? The red color is something we need to fix. Similarly, in doctors' offices, clinical screening is standard practice and is required for reimbursement for some primary care visits. Specifically, doctors weigh and measure patients, calculate BMI, and if a BMI is over a certain level, a patient is told you have obesity, you have overweight, and it is framed as a problem. So there's an assumption behind this, right? So the assumption is that people with higher body weights should think their weight is a problem. In our lab, we've wondered, though, what happens when people think they're overweight? Like, what does it mean when you think your body weight is the problem? How does that actually link to health, and how does that actually link to health behaviors? And so we've done a series of studies that assess the concept of weight misperception. And what weight misperception is when you think your body weight or your weight status is different from what it actually is. And the way that we assess this, particularly in samples of higher body weights, we ask them, how do you perceive your weight? If they answer overweight or very overweight, we say you're an accurate weight perceiver. What you think about your weight matches what your doctor might think about your weight. Some people may answer that they're about the right weight or that they're underweight or very underweight, and those are folks that we call weight misperceivers. They don't actually know what their weight status is according to a growth chart or sort of a BMI chart. But sort of counterintuitively, we have looked at behaviors of people who misperceive their weight. So that is people with high body weights who think their weight is just about fine. And we compare those to those that think they overweight. And people who think they have a high weight have fewer healthier behaviors. They eat fewer vegetables, they sleep less, they exercise less. They have more disordered eating, behaviors like self-induced vomiting, binge eating. They have more depressive symptoms. They gain more weight over time. They have more internalization of weight bias, so they feel a lot of distress about being mistreated because of their weight. And over time, they have higher blood pressure. So we see similar findings in an experimental design we've done in our lab where we bring in adolescents with high body weights and we provide motivational interviewing. And what motivational interviewing is a gold standard of behavior change counseling where you talk about health behaviors, again, with the idea of motivating people to improve their health. But in our study, we randomized people to either be told their weight status or not told their weight status right before we do this motivational interviewing. So half the adolescents are told, you have overweight, your BMI is in this category, and the other half, we don't even tell them their weight, we go straight into motivational interviewing. And this is what we see. When we tell people their weight status before we do this type of counseling, the adolescents leave feeling body dissatisfied, their mood is worse, and they're internalizing weight bias more. The exact opposite is seen when we don't talk about weight status. They feel more body satisfied, their mood is better, and they're less likely to internalize weight bias. So how do we interpret these findings? So we think that weight normative approaches, by overemphasizing weight, may underemphasize the importance of health behaviors, and by doing so, may not produce the intended outcomes and could actually be harmful to those they are designed to benefit. Instead, we're testing and we propose alternative strategies that avoid narrowly focusing on weight, considering the unintended consequences of focusing or fixating on weight, and instead focusing on health behaviors and general well-being.